coming to other group of antibiotics that we have to understand, out of which most important is vancomycin. It has a good MRSA coverage, also has a good coverage against resistant gram-positive organisms, but it do not cover gram-negative. Oh, this is wrong. Gram-negative. You have to monitor for renal toxicity. Next is aminoglycosides like amikacin, gentamicin. It has excellent gram-negative coverage. So usually we combine vancomycin and amikacin or vancomycin and gentamicin for both gram-positive and gram-negative coverage. It has poor lung penetration. It can cause nephrotoxicity and ototoxicity. Coming to the macrolides, like azithromycin, clarithromycin, they are used mostly for atypicals like Mycoplasma chlamydia in atypical pneumonia. Tetracyclines like doxycyclines in rickettsial infections, atypical infections, cholera, and must keep in mind that you should avoid it in less than 8 years of age children, and it is not a hard and fast rule. If there is a requirement, you can give. Why are we avoiding it? Because this drug deposits in bone, suppress bone growth, dental discoloration, and dental defects can be formed, and that might be permanent. Next, coming to fluoroquinolones like our ciprofloxacin, levofloxacin, they have good gram-negative coverage. Levofloxacin is usually used in lungs. Cipro is rarely used because we have better drugs for Pseudomonas. And side effects of fluoroquinolones are cartilage defects. Coming to metronidazole, it has anaerobic coverage, covers MBBS, GRDSs, used in brain abscess, intra-abdominal abscesses. Lenizolid, it is an MRSA. Advantage is IV and oral, both can be given. It has excellent lung penetration, but we have to keep in mind about the thrombocytopenia and keep monitoring the platelet count. Also, it is a reserve drug. In case of TB, we try to use it less. Then is the colistin. Colistin is the last resort drug in ICU. It acts on multi-drug resistant gram-negative bacteria, Acinetobacter, but is nephrotoxic, so we should mostly avoid it. If there is no other option, then only we will give it. So these are the different resistant mechanisms. What bacteria do to keep themselves safe, which class of antibiotic is affected, what are the example of it, and what are the important resistant organisms. Beta-lactam production destroy the antibiotic enzyme ring seen in cephalosporins and penicillins. Organisms like MRSA, Klebsiella. Carbapenem means carbapenems. In these strains, we have to be careful. Altered PPBs, penicillin binding proteins, that is in beta-lactams, so beta-lactams. And organism is MRSA. Altered cell wall target means vancomycin cannot bind, so it is resistant to vancomycin. This is vancomycin resistant Enterococcus. Efflux pump defects means antibiotic is pumped out of the bacteria, like in case of macrolides, tetracyclines, quinolones, seen in Pseudomonas and staph organisms. Reduced porine entry means antibiotic cannot enter itself, seen in beta-lactams and carbapenem group of drugs. In porine loss, organisms like Pseudomonas and Klebsiella exhibit this kind of resistance mechanism. Alternative metabolic pathway like bypass the blocked folate pathway in case of trimethoprim sulfamethoxazole. Go back and see that we have discussed in E. coli and MRSA. Lipid A modification and biofilm formation. Biofilm formation, remember staph, Pseudomonas and Acinetobacter. Next, if this organism has a typical resistance pattern, then what is the sensitive drugs you should use? This is a very important slide. MSSA, usually sensitive drug is cloxacillin and cefazolin. If it is MRSA, means methicillin resistant staph aureus, due to altered PBP, then you give vancomycin or lenizolid. Vancomycin is better preferred because lenizolid is a reserve drug. If it is also resistant to vancomycin, vancomycin resistant Enterococcus. Why? Because vancomycin target alteration happens. You give lenizolid. In case of extended spectrum beta-lactamase E. coli or Klebsiella, there is third generation cephalosporin resistance, you give carbapenems. In carbapenem resistant Enterococcus, you give colistin or any newer combination. Pseudomonas, piptaz, cefepime, meropenem will work good. Acinetobacter, extreme MDR, give colistin. Pneumococcus with altered PBP, macrolide resistance, give vancomycin is a better option. Anaerobic coverage, when to think of anaerobic coverage? Abscess, aspiration, GI infection. And what to give? Metronidazole, piptaz, carbapenem, clindamycin. What is clindamycin? We did miss that. So clindamycin is a lincosamide antibiotic which will act on the ribosome, bacteriostatic, and it is cidal at higher concentration. Gram positive coverage and side effects being pseudomembranous colitis, which is a very life-threatening side effect. Atypical coverage, you have organisms like mycoplasma and chlamydia. Then what to give? Macrolides and doxycycline. Coming to pharmacodynamics, there are two main things, time dependent and concentration dependent. Time dependent means seen in case of beta-lactams and vancomycin, correct dosing is required for extended infusion because it needs time to show its action. Next, concentration dependent like aminoglycosides and fluoroquinolones. Once daily is sufficient, but you have to give it in higher dose. Just a point about tissue penetration. CNS penetration is good in ceftriaxone, cefotaxime, meropenem, vancomycin. Lung penetration, think of macrolides, linezolid. UTI, urinary tracts, aminoglycosides. Bone, clindamycin, vancomycin. So coming to the last part of the discussion, you have to always start empirically based on the discussion we have had till now, then shift to definitive management and eventually de-escalate your therapy. This is nothing but antibiotic stewardship. Always ask this question, which drug will reach the infection site and kills the organism without causing collateral damage. So let us all consolidate this knowledge with help of an example. This is a 4-year-old child presented with fever, cough, tachypnea, crepitation, sick or dull looking. This suggests respiratory tract infection. Sick or dull looking is mostly because of bacterial infections. So infection site and most common organism. Respiratory tract, most common organism we have already discussed. In this age group, it is mostly viral, but because the child is sick looking, dull, it can be bacterial. Streptococcus, H. influenza are our first thought. Then what we will give? We will give ceftriaxone. Why? Because it has excellent pneumococcal action and good gram negative coverage as well with good lung penetration. Right? Next, there are few situations and we will see what we have to do in the situations. So if this child is not responding to ceftriaxone even after 2 to 3 days with persistent fever, worsening distress and toxic look, then what you will do? You have to reassess your diagnosis and complication. Think of MRSA, empyema or necrotizing pneumonia. Also resistant pneumococcus is one chance. Next, you will add vancomycin and repeat imaging cell cultures if not already done. Next thing, if child is recovered, well and good. If not recovered, this is a hypothetical situation when child has not recovered and has progressed to severe pneumonia requiring ventilation. Then microbiology changes from community to hospital acquired organism now. So we will think of Pseudomonas, Acinetobacter, extended spectrum beta-lactam is gram negative. Next step would be ceftriaxone to meropenem and continue vancomycin if MRSA is still concerning. Here the child has improved initially but now developed new symptoms on ventilator. Child is having increased secretion, worsening condition, increased requirement of oxygen. Then what we will think of? Ventilator associated pneumonia. What is the likely organism here? Pseudomonas, Acinetobacter, Klebsiella, MRSA. Then what do we do next? We have to take ET aspirate culture, repeat blood culture, assess the antibiotic sensitivity and we have to give antibiotic based on that and continue broad spectrum multi-drug resistant coverage until the results are available. If you have to start one drug before the culture arrives, it should be colistin. And if the culture shows MDR Acinetobacter, which is resistant to meropenem, then definitely you have to start colistin as a last resort therapy. I hope this made antibiotics a bit clearer. If you have any doubts or any situation that you are dealing with regarding decision of antibiotics, then please do comment and we will definitely discuss.